Bangalore chapter. Burn injuries are global public health problem, accounting for an estimated 180,000 deaths annually, largely in low income and middle income countries. In India itself, 7 million injuries and 1.4 lakh deaths are reported annually. High calorie diet with parenteral as well as the enteral support are very crucial for the recovery as well as the treatment of the patient. Today, in our case study presentation, we are going to discuss medical nutrition therapy in second and third degree burn with H1N1 pneumonia and severe ARDS. And the two experts are with us. I would like to request to show their slides, please. Dr. Nikhil N. He is a consultant critical care medicine in Nestor Hospital, Whitefield, Bengaluru. He is a skilled critical care specialist with a strong academic as well as the clinical background. He completed his MD in anesthesiology from Command Hospital, Air Force, Bengaluru under Rajiv Gandhi University of Health Sciences, followed by DNB in anesthesiology. He further specialized in critical care medicine at Manipal Hospital, Bangalore, holds an FNB in the field. He is certified in basic and advanced cardiac life support and has additional training in healthcare quality implementations. His area of expertise are fluid and nutrition management in critically ill patients, rehabilitation in critical care, end of life care, and quality improvement in healthcare. Dr. Nikhil has contributed to multiple national and international publications reflecting his commitment to research and advancing critical care practices. We welcome Dr. Nikhil to listen and know much more about the case study from him.
Sorry, I don't understand.
For that
Welcome,
introduction. Yeah, thank you. So much ado, let me just start off. Are my slides visible?
Not yet. Yeah.
Yes. Excellent. So, the talk today is a short case I'll be presenting, all which my colleague takes through the nutritional therapies. So this is a young lady that we have severe acute respiratory distress syndrome, and respiratory to our usual ventilation oxygenation strategies and required advanced intracorporeal life support to maintain oxygenation. So she was a 35-year-old lady who was gainfully employed. A set of coincidental occurrences, starting with an accidental injury at home where she spilled some hot water on herself at her residence. About 10% of her body surface area was in upsize.
Hello.
Apologies. Seems to be something with the internet.
Yeah,
Am I
Dr.
audible?
Nikhil. Yeah, he says you are very much.
I'm back. Yeah. Yes. So, as I was saying, this is a 35-year-old lady who spilled hot water at home on herself, accidentally injured her chest, abdomen, upper thighs. About 10% of her total body surface affected, and she was treated on an outpatient basis with dressings and serial monitoring. From the time that she had this injury, again, may just be unrelated. She had progressively worsening breathing difficulty and fevers. And about 24 hours from onset of this these new issues, she had to be admitted to the hospital where she was found to be hypoxic, tachypneic, and tachycardic. All right. So at the time of her initial presentation, when her labs were done, they were largely unremarkable except for the ABG, which showed some hypoxia. But her CT thorax at that point in the outside hospital showed extensive bilateral consolidates in the lung, but there was no evidence of any clots or emboli. Her echo did not suggest any ventricular abnormalities or contraction abnormalities. A flu panel was done outside, which picked up H1N1 positivity. So what we are now dealing with is a patient with a community-acquired viral pneumonia, right? So this was an image that we had acquired much later in the course of her illness. Just wanted to show it as a representation, right? So you see the extensive consolidation bilaterally that is there here, signifying the extent of lung injury that she had. This in fact is an X-ray which is 20 days into her illness. So you can only imagine how bad her lungs would have been at the time of presentation, right? So antivirals, oseltamivir was the therapy of choice for H1N1 influenza. Actually, in the outside hospital operation support, non-invasive ventilatory strategies were attempted. However, she did benefit from that. So she had to be emergently intubated. The moment she was intubated, as expected, somebody with severe ARDS, she had severe and extremely high lung airway pressures, peak as well as bladder pressures, which needed prone ventilation as a rescue strategy to try and keep the lungs protected. She was prone ventilated the moment she was admitted, and close to about 16-20 hours into her proning cycle was when a referral call was made to us at Field, regarding extracorporeal life support center. So we went, assessed the patient, spoke to the family, and made a plan to shift this critical patient to our hospital. At this time, we were dealing with diagnosis of a refractory hypoxemia in the setting of severe acute respiratory distress syndrome in a patient with secondary birth with and the patient was in shock, requiring vasopressin and infusion to we had suspect sepsis also patient. So we had multiple challenges. The word go. So from our initial management, she was continued on invasive ventilation, and the moment she came to us, we initiated uh, veno-venous ECMO for her. This was a 25-day run of veno-venous ECMO, along with invasive lung protective ventilation with ultra low tidal volumes. Right. So this 25 days saw complications, which included rounds of sepsis, rounds of bleeding, episodes of clotting of the oxygen requiring an oxygenator. The AKI required multiple rounds of CVV HDF as in renal replacement therapies. Once we were safely off ECMO, she had to be reprone once more as a strategy to, you know, help the lungs recruit better. And after all of these, from the day she got admitted to us to finally getting decannulated from the tracheostomy on a day 50 and a discharge to her house subsequently, about a 50-55 day hospital stay for her. We consider this a remarkable achievement, and this is a testimony to great multidisciplinary work spanning across medical teams, nursing teams, other allied healthcare teams such as nutritionists as well as our physical therapy teams. Wouldn't have been possible, all those working seamlessly as a now care of this patient with challenge. First was managing oxidation. Obviously, somebody with comes to us with problem with oxygenation. That is a fundamental problem that we are dealing with, and managing that itself is a challenge. So we had to go through multiple invasive proning as a rescue strategy, followed by a VV ECMO, which was the final ditch attempt until the lungs were better. While you're managing somebody on an extracorporeal that manage coagulation, because this has to balance the ability of the membrane to at the same time not clot, have pressure gradient across it, and this is basically heparin is required for the functionality of the membrane. That is what we tried to achieve. But in this patient, she had bleeding within the tracheal tree. So we also needed to manage anticoagulation appropriately such that she doesn't have to go in and do multiple interventions. As my will let you know subsequently, all of these interventions did have bearing on how we were able to manage her nutrition, also how it limited our ability to manage her nutrition.
Apologies. Looks like Dr. Nikhil has a bad network. Kindly apologize. We are just getting him back. I think he's back. Yes. Yeah. 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 Yes, doctor. No problem. Yeah. No worries. No worries. Please start.
Yeah. Yeah.
Please continue,
So
doctor.
we were discussing challenges to our management of this patient. So secondary such as bleeding, the multiple interventions, of these management of nutritional therapies in this patient. We were right hand from American Society of Paediatrics and
Your presentation
which
is
made
not, your slides are
recommendations
not
for
moving, doctor. Excuse me. Your slides are not moving, doctor. Can you please move the slides?
yes,
Yeah.
we okay. Are you able to see the movement right now?
No,
I'm
I
on slide
can't.
number 8.
Can we have doctor's slides, please? Back and kindly help us with the doctors. Yeah, doctor is here. Yeah.
I'm back, but it seems like I'm worried that I might get disconnected again very quickly. So
No worries, no
without
worries.
too
You
much,
continue,
let me
doctor.
just try and quickly. Yeah, I'm anyway on my last slide.
Yeah,
I
yeah. No
hope you can
worries.
see the slide right now.
Yes, yes. Yes, I
Yeah.
can see this. Yeah.
So the so yeah.
Please
So
continue.
this
Yeah.
one interesting image that I picked up from the Journal of Dental and Parental Nutrition Aspen guidelines. So all of these are the perceptions that people have as to what the barriers of enteral nutrition and parental nutrition are in patients receiving ECMO support, right? Ordinarily, as a critical care practitioner, I prefer enteral nutrition in all my critically ill patients as against parenteral nutrition. But most often, people perceive that unstable hemodynamics could result in gut ischemia, or malperfusions can cause bacterial translocations, all of these things, and that the risk of leading to therapeutic resistance. All of these data support that we are injecting our patients who are on ECMO, but most of these are really hold no true, evidence and scientific backing, including the use of sedative medications, does not really affect GI motility to an extent where it would prevent us from doing enteral feeding, right? Frequent interruptions, unfortunately, is one of the problems that we will have in any ICU. Despite whatever attempts are made to reduce those incidences, that is something that is always going to be there. And somebody with a long ICU course and sort of grave critical illness, you will see that after 50, 60 days of illness, where you have frequent interruptions in feed, their calorie deficits are so high that you will see that they are significantly malnourished at the end of their ICU stay at the time of recovery. So most of these are perceptions to our nutrition, but they are actually not true barriers to us feeding our patients, right? So this was a short case summary. So to summarize, we had a young lady with ARDS as also, burns injury, which also causes some amount of protein loss from the cutaneous tissue. So we had challenges on two fronts already that we were dealing with: unstable oxygenation, bleeding issues versus anticoagulation issues on ECMO, and we needed to feed her. So this was with this background, yeah, I hand over back to you, Dr. Priyanka. Apologize for the many
No worries,
drops
not at all.
Yeah.
All these technical glitches keep happening. It's okay, absolutely fine. Thanks for your insight about the case. Now I would request Backen to kindly help me with the Madhurima's slide, please. Yeah. So now to discuss about the nutritional management, we have dietitian Madhurima Ghosh. She's a clinical dietitian with Astor Whitefield Hospital. With around 2.5 years of experience in clinical nutrition and dietetics, she holds an MSc in Dietetics and Applied Nutrition from Manipal Academy of Higher Education and is a member of ESPN Bangalore chapter. She has also been recognized for her academic excellence, winning first prize for the scientific poster at Esther NutriCon 23 and IAPNGI Core Group annual meet, where she presented on nutrition management in a case of primary sclerosis congenital IBD following a living donor liver transplant. Her areas of expertise are critical care and transplant nutrition, sports and clinical nutrition, preventive health care, pediatric nutrition, type 1 diabetes, and OBG nutrition. Over to you, Madhurima. We all are waiting to listen from you about your medical management in this case.
Yes. Okay. Good afternoon, everyone. Thank you for that great intro, ma'am. I'm grateful to be presenting in this this session. So as we got the brief about the clay case, our sir has already informed us regarding the whatever the briefing of this case, the medical terminologies and everything we have come to know. So I will tell you from our point of view what are the things that we did. Obviously, in terms of obviously we took suggestions from our doctors that what they expected us to do, and also we put on our inputs on whatever we did. So coming to, I will start presenting my slides, so you can
Yes,
help me,
please.
ma'am, to check if my slides are visible.
Can we please can you share your slides? Can we
Yes,
please
one
have
second.
Madhurima's slides?
Yes, 1 second, ma'am. I'll just share it to you.
Yeah, please share.
I'll be sharing.
Take your time, no
Yeah.
problem.
Can you? Yes. Can you see my slides now?
No, can't see your slides. Yeah, I think it's coming.
It's already sharing.
Yeah. Now you can just start.
Okay.
We can see your slides. Yeah.
I'll just start. Okay. So as we know, we will be discussing about the medical nutritional therapy for the second and third degree burn with H1N1 pneumonia and severe ARDS. So coming to the patient profile, as sir has already explained, she was a 35-year female. She was a, if I tell it in terms of like the food habit, she was a non-vegetarian, and she was with us for almost 2 months, 22 days. Okay, initially she was with us in the critical care, that is in the ICU, for a pretty long time, and then she was shifted to ward, where also we were taking care of her. And then, as we already know the case details, so I'll not be going in detail in the case details. So as we know, we already discussed it, that 8 to 10% of the total body surface area burns were there. And also she needed like ECMO support, and also she was having AKI and also ARDS, which needed like because of the oliguric AKI, she needed intermittent dialysis also. And also, if you see in terms of the nutritional assessment, she was a SGA. And yes, so these are the anthropometric measurements. Obviously, initially she was admitted in ICU, so we didn't have a lot of like anthropometric measurements, and we didn't even like get to like check her hand grip and also like the muscle wasting. But once she was able and like she was like slightly stable, we were able to take her hand grip and everything. So the date in the date of and during the date of admission, we only were aware about her height, and that was also very approximate. And then in the later stages, after almost 1 month of admissions, we checked her weight and also her BMI and hand grip strength. All these things were checked for the patient. So now we can see like during the hand grip strength also, from when we started checking till the discharge time is like 9 10 24. So that time it was still weak, but when she came to us after 2 months for a follow-up, we saw a significant increase in her hand grip strength, so that her muscle loss was not very significant after she got discharged. That means she was literally like eating well and also following our instructions. So now coming to the biochemical parameters, we were checking all her biochemical parameters. So obviously she was with us for like almost 2.5 months. So I cannot have like all the details, but wherever we saw a fluctuation, that's what I have mentioned here. So you can see like GRBS also was fluctuating. There was, even though she was not a diabetic case, there were certain times the GRBS was going above 200 to 250. And as she was like having AKI, you can see there was a frequent increase and decrease in the creatinine. So our nutrition also depended upon how her creatinine and other all electrolytes and other all parameters were increasing and decreasing. And our choice of oral nutritional supplements also varied because of her condition or because of her parameters throughout this day. So now you can see these are few of the nutrient drug interactions. Okay, so she was on an anticoagulant. So yes, vitamin K, my vitamin K. Oh, 1 second. Yeah. So vitamin K, it was restricted for her, anyway she was on the feeds, so we didn't have to think about it a lot initially. But after once she started taking oral feeds, that time we had to like check about the vitamin K rich foods. And then also there was other drugs which was which would help in fluctuating her blood sugar, blood glucose levels and everything. So these are the few relevant nutrient drug interactions that I found in her profile, like in her drugs, so which I have mentioned. Coming to the this is a food frequency table. So this all was collected from her later stages. So initially or later stages, and also with the attender. Okay, because the patient was not in that position to give us what she give us a history of what she used to take, what is her what was her food frequency, or what and all was her daily pattern in her home. So we were in regular touch with the patient's attender, and he was the one who was giving us all this information. And hence once we started with the oral food, that is when the RT, the enteral feeding was weaned off, that's the time when we started incorporating her habits or food habits in her diet. So this is a home record. This is before she was admitted to Aster. This is what we collected from our from his attender. So you can see, like, it was a very typical a meal which like around more of like, carb rich foods. And like, yes, I have calculated the B12 and zinc and everything. So it was nothing very it's a very typical South Indian kind of a home recall that we can see. Now coming to our pet statement, so what was the problem was we were facing? Obviously, there was an inadequate oral intake. She was not in that position to have an oral intake. So etiology related to prolonged critical illness, extensive burn around 8 to 10% of total body surface area, and complications such as the ARDS, H1N1 pneumonia, and AKI. The signs and symptoms as evidenced by the requirement of ECMO, inability to tolerate NG feeds intermittently. So we did start with NG feed, but you can see when I show you my follow-ups that there were a lot of times because of sepsis there was like intolerance. So there was time like we were keeping her, like the doctors and us together, we were keeping her on NPO, and again restarting with the enteral feed. So there was a prolonged NPO status, dependence on NG feeding for over a month, and delayed progression to an oral diet. So this is the diet progression, like the throughout the entire duration. So if I could give you like a summary, so initially she was NPO, then we started we started with around 100 ml of the hourly 100 ml second hourly NG feed. Then she was tolerating, and we initiated with 150 ml. And then when we saw that 150 ml she was tolerating, we continued with 150 ml. But then again there was like a fluctuation in her creat, and there was AKI, there was like dialysis required. So we changed the type of oral nutrition supplement. And then there was slight intolerance, so we cut down the feed to 100 ml. Then again there was like a lot of intolerances, so again we kept her NPO for almost 5 days. Then again we started with 100 ml. And then again, along with 100 ml, we didn't increase the feed, but then we started orally. We have an in-house allotherapist. So we did not totally wean off with the NG tube, but along with NG tube, we started seeing like slowly if she is able to take orally or not. Then we started with orally clear liquids and semi-solids. And then it was a combination of like orally semi-solid. We didn't stop the supplement though. We were giving her oral nutrition supplement along with the semi-solids. And then at the end, during discharge, she was on oral nutrition supplement along with the normal food. So how did we calculate the energy targets for the ECMO patient? So we went with a standard approach of SPEN and SPEN guidelines. So around 25 kilocalories per kg per day. That is approximately we were getting around 1,400 kilocalories. So the initial phases, our like that is in the acute phase, that is in the 3 to 4 days after the admission, we tried to like get her around like 70% of the target, and then slowly increases. That's why we started with around 100 ml. Second hourly, then we started increasing it to 150 ml. But yes, we progressively increased it, but she was not tolerating it, so hence we again had to reduce the feed. But yes, after 7 days, our objection was to like achieve the full target, that is around 25 to 30 kilocalories per kg per day. So if I would so I will show you the actual follow-ups. So you can see that initially we could like around from 19 to 21st, so around 3 to 4 days, we were meeting around 999 kilocalories and 38 grams of protein. And that is only one type of supplement, that is our ONS that we were giving. It was a peptide based supplement, and we were meeting up to 70% of our target. That was what we were targeting, of us 70% of our total kilocalorie target. And then as we started, she was tolerating it all good, motions were passing. And then slowly we started with 150 ml second hourly, and then we could reach up to the full potential, like how much we wanted, around 1,400. We were reaching that much amount of kilocalories, but we were getting good amount of protein also. And that time her protein requirement was needed, because she was in a hypercatabolic state. But once we started giving her more protein, and also because of other kind of like issues, she developed AKI. So her creat started fluctuating. So we kept the same feed, that is 150 ml second hourly only, but we changed the type of oral nutrition supplement we were giving. So we started giving her a renal based oral nutrition supplement. So it was a combination of semi-elemental, that is we were giving initially, along with the renal ONS, that is oral nutrition supplement. So we were getting around 1,500 kilocalories. That is more than what was we expecting, but we cut down the protein a bit, because obviously her creat was also fluctuating. And then due to intolerance, again, we had to cut down the feeds to 100 ml second hourly, and we were again back to 70% of our requirement. And then again, for almost 5 days in between, she was on NPO. And then slowly we started incorporating oral feeds. So when you see, like when we were incorporating oral feeds also, if you see in this from 10th to 21st, you can see, like, you know, we were giving her the NG feed was not stopped. We were giving 100 ml of second hourly, but we tried to like maintain the another 400 kilocalories which we were not meeting through NG through the oral liquids. In the initial days we were getting around 200 to 50 kilocalories. You were not able to take a lot, but yes, later stages it was around 350 400 kilocalories. So together we were kind of achieving 1400 kilocalories. So that's the about follow up. And you can see in the later stages, once we started with like semi solids and all, we were meeting her requirement. At the end, during her discharge, we gave her a plan of around 1700 kilocalories and protein up to like 73 grams. And along with that, we were continuing with the supplement, but we were not continuing with the what supplements we were giving through NG feeds, not the semi-elemental in the renal formula. By that time, her creat also has come down. We were giving her a good high protein supplement. So that is the follow-ups that you can see. So coming to our intervention, like what we were trying to do, so the short-term intervention, if you see, is like it was to meet the adequate nutritional requirement through the feeds before the oral intake starts, and weaning of the feeds as the oral intake improves, to meet the increased energy requirement as burns and pneumonia adds to the metabolic stress, significantly increase energy expenditure, to provide the necessary protein intake without causing the creatinine levels to fluctuate, as this is necessary for the immune system function and muscle maintenance and wound healing. And also, as it is a burn case, they are needed for a proper fluid management. Is vital for the burn patient, and they are at the high risk of dehydration and electrolyte imbalance. And close monitoring of fluid balance and electrolytes, example sodium, potassium, chloride, was also very important. And one more thing that we were also calculating is about the amount of magnesium and zinc that we were giving. As we know, like magnesium and zinc, it is important for the protein metabolism, wound healing. So yes, magnesium and zinc was also one of the things. Once she's not in, when she was on enteral feeding, but once she started having like oral feed, those that time also we were, that's the time we were like focusing a bit on micronutrients also, like more majorly on micronutrients that time. So long-term intervention, yes, obviously we wanted a complete weaning of feeds. And when she was getting discharged, she was completely out of feeds, so we were giving her normal diet, and to prevent micronutrients deficiencies, and to be physically active and lead a healthy lifestyle. So you can see my food exchange list. We have tried to like incorporate, as she was a non-vegetarian, and those kind of thing, all the non-veg items also. And her creat and everything had come down, so we were giving her like protein and energy. That's per her as calculations, and around 1.5 grams of protein per day is what we had calculated for her. This is the sample menu, like what we had planned. So we had not stopped with the ONS. So along with the ONS, we were getting around 1,756 kilocalories and around 74 grams of protein, and fat around 44 grams. So yes, these were the MNT goals and principles. I will not like read it through, like, but these are the major things that I have already explained to like during my presentation, that we were like after she was weaned off of the ONS, we were majorly focusing on 3 major meals, 2 major meal pattern. And this and also the initial feeds and tolerance were administered based on like the initial feeds we were all like giving to the patient according to the tolerance and the parameters. We didn't have like a perfect strategy that we were following through, but we were checking the parameters and everything, and then we were like changing it accordingly. And as I told, the supplements also were adjusted according to the patient's tolerance and biochemical parameters. And fluid restrictions, and due to the fluid restriction and frequent intolerance, the patient's calorie requirement were not fully met initially. However, we tried meeting it later. And also the protein requirement adjustment also we did because of the creat fluctuation and everything, and plant-based protein on the later stages. And the discharge plan was based on mostly on her ideal body weight. But yes, she was on the overweight category, so initially we didn't focus a lot on like her to like have like a calorie restricted diet or anything. After she came back to us 2 months later, around in December, that's the time we gave her more, where she could even like maintain her weight. So if you can see, this was our progress. So initially, kilocalories progress, how it has initially, it was only 999, then 1400, and initially at the end she was taking around 1300 kilocalories orally, and the protein requirement also, you can see how there was a progression. Yes. So in conclusion, the dietary plan was carefully tailored to meet the patient's specific needs, with focus on promoting optimal digestion, support kidney function, and ensuring gradual nutritional improvement. Supplements were progressively modified to suit the tolerance and biochemical parameters, while for focus on a plant-based renal-friendly foods aligned with her health goals. Discharge plan based on her ideal body weight ensured a personalized approach on long-term health and recovery. So yes, I guess I'm done with the presentation. So I hope I was able to deliver what, like, whatever was required in this case. So thank you so much for giving me the opportunity.
Thank you, Madhurima and Dr. Nikhil. Can we have some questions?
Yes.
Audience can ask the questions in the comment section on YouTube as well as on the Facebook. Uh, okay. How did ARDS and ECMO impact your nutritional approach?
Yeah. So we didn't treat it as such as a, like a ARDS and ECMO support. We were usually taking it as a how we would like go forward with a nutritional support for in terms of a ICU patient. So in all the ICU patient, as sir told, we initially start as fast as possible with the enteral nutrition, and our aim is to first acute phase. Our aim is to like at least fulfill 70% of the requirement, and then slowly progress for the full kilocalories what's required for the patient. Anything from sir's side, sir?
Dr. Nikhil, would you like to add upon?
I think that's appropriate. Like Madhurima told us, in most critical care units, for all our critically ill patients, irrespective of whether they are being ventilated or they are on ECMO, the considerations largely remain the same. So, especially for our intubated patients, the moment we put in a breathing tube for them, we also put in either a nasogastric or an orogastric tube. So that begins our conversation of feeding and nutritional support for our patients. So, ARDS and ECMO particularly, it does not impact the approach, but perhaps it may, modify how we may calculate the needs of energy that the patient may have. Right.
Correct. Okay, so the next question is why was enteral nutrition preferred over the parenteral nutrition initially?
Yeah, as sir told, right? Initially, like we as soon as the patient is like admitted, we our first approach is enteral nutrition, because there are less risk of infection, and also it prevents there is like a gut mucosal integrity also will be intact, and also there are other complications when you go to parental nutrition. So it's if the gut is functioning well and there is no distension and other like problem, I guess enteral nutrition is the best way to start with the feeds. Even though for this patient there were like a long gap of like around 5 to 6 days where we have kept the NPO, but then again soon as the issues were resolved, again we started back with enteral nutrition itself like progressively. Like we didn't start again back with 150 ml, we started with 100 and then we went on with the oral semi-solids and everything. Yeah.
Okay. Would you like to add, Dr. Nikhil, something?
I would say that we like to challenge our team of dietitians and nutritionists at Aster, uh, because you start them on parental nutrition, things are probably way too simple and easy, perhaps. So,
Mm,
you throw challenges at our team of nutritionists from day one. It changes on day two. It needs change on day three.
yeah,
And
I can see
again,
all the graphs and the tables were, in fact, the creatinine also improved very considerably. So, good job by the team of dietitians.
yeah,
Proud of you.
Thank you.
yeah,
Thank
Yeah.
you
So
so
yeah,
the
much.
excellent
next,
job. So,
yeah.
yeah, so
So,
just to summarize, we always prefer enteral nutrition in all our patients. Parenteral
mm,
nutrition as a consideration is only if they have intolerance to enteral feed, which we expect is going to last for longer than a week, or if there
correct.
is some evidence of a bowel ischemia or a bowel leak, or there is an anastomosis which is not healing in about 7 days. That is the only time we will even consider parenteral nutrition, but otherwise enteral is the way to go.
Yeah, and that is the next question also. So I think you can even add up on why was the early enteral nutrition important in this patient particularly. So would you like to add something, Madhurima?
As we said, ma'am, it is a hypercatabolic, hypermetabolic patient, right? There is burn, and also a patient is having ARDS and other issues, pneumonia. So I guess the early enteral nutrition helped us to not to have like a very muscle wasting. The patient was fine; there was no muscle wasting as such, and also it also supported the overall outcome of the patient, like how the patient was. There in the ICU, and how it the other parameters and well-being of the patient. So I guess that did help in certain way the enteral nutrition, the early involvement of the enteral nutrition. Yes.
Good, good.
Anything
Next
else,
question,
sir?
please. Yeah, I think there's another. Did the prone positioning of the patient affect the enteral feeds?
I guess we from our side we didn't change anything in terms of prone positions, or anything to add regarding the prone position of the patient.
Like you said, there is no major consideration in terms of feed volume or feed quality or calorie density when it comes to a patient who's in prone position. Gastric motility and digestion will happen irrespective of the position of the patient. So same principles apply whether they are in supine position or prone position. So if we suspect that there is gastric feed intolerance, that is when we look for gastric residual volume and then make our interventions and adjustments based on that. But
Correct.
per se, position itself does not contribute to us making any changes to our plans.
So in this patient, that was not
Yeah,
applicable
nothing
as.
with it was all fine except that one part where there was like intolerance. I guess the patient was tolerating the feeds well, passing motions on a regular basis. So there was no problem in terms of digestion and
I
intolerance
would like
except
to
that
give
one.
I
Yeah.
would like to give credit to your counseling skills as well, because I think such patients need a lot of psychological as well as the nutritional counseling. So, well done. There's another question. How should energy targets be calculated in the patients receiving ECMO? I think you have already explained, but would you like to
Yes.
just put in some more
Huh.
emphasis on that?
Okay, so I had put it up in my presentation, ma'am. So yeah,
Yeah,
as such, we don't have like it in term like a specific guidelines for ECMO patients. So as far as ASPEN and ISPEN guidelines, we usually take the same as for all the ICU patients. So that is your 25 kilocalories per kg body weight.
hmm,
And initially we in the acute phase 70%, and then we progressively increase it. But one thing in terms of ECMO is like we didn't want it to overdo the CO2 production, right? So we don't
hmm.
overfeed the patients. That's what is requirement. That's what we do. We don't go to increase the kilocalories and protein more than what is required. So what
Requirement.
is, yes, because the CO2 like production, we don't want it to go more. So
Yeah.
yes, that's.
Okay. Doctor, would you like to add upon something?
It has been beautifully summarized by Madhurima, and as she rightly pointed out, both ASPEN, ESPEN, as well as the ELSO, the Extracorporeal Life Support Organization in 2025, they have given us that the calculation of 25 calories per kg body weight is the most simplest and validated way to manage nutrition for a patient on ECMO, because indirect calorimetry or any other calculations, erratic, difficult, may not be reproducible, not validated. So what Madhurima has explained already in her
Yeah.
slides and again
So we are
summarized at
getting
the
a
end,
comment.
I think that's
Great
the way.
case. Yeah. Else we move forward.
Yes,
The
ma'am,
next,
your screen is stuck, ma'am.
is it okay now?
Yes, yes, yeah. Yes, ma'am is out of the question. She's logged out, I guess.
So it was a good session, I think. I'll just
Thank you,
wait
sir.
for ma'am to log in. Yeah,
Yes, yes.
we'll just wait for ma'am to log in and then
I guess she's not aware, sir, that sir, she is logged out. I'll just send a text to her.
So thank you all for your comments and good show, the team. And audience, if there's
Yes.
any more questions, please feel free to comment. And if the session is being closed, we will try and get back with answers to all of you all as best as possible.
Um, I'll just try texting ma'am, sir. I guess she's offline. Trying calling ma'am. She's trying to log in. I guess there's some issues from her side. She's trying to log in.
Oh, no worries. Madhurima, there's another interesting question. Would you like to take that? How should such a patient take care of the diet once they're back home?
Yeah. So as we told, like initially, like it was all NG feed and everything. So we were trying to like, in my slide also, I had told about the short-term interventions and the long-term intervention. The short-term intervention is when we were like the patient was in the ICU and we were trying to focus on the getting the parameters back in line and trying not to getting the calorie requirements met. But once the patient was a normal feed and then everything she was having normal diet, as she was an obese patient. First point that she was an obese patient. So we didn't try to restrict her calories and protein first initial 2 months, but we told her to come back to us in OPD basis on during after 2 months, and we checked her hand grip. There was good amount of muscle mass, that there was no muscle wasting. Her hand grip was in the normal stage. So then we gave her a plan which would help her sustain her weight, that is to get back her weight with according to her ideal body weight, and also protein also accordingly. So we were not checking about her like weight loss, or like protein also have to be like maintained initially. But later stages, when she was fine and we checked her, there is no muscle wasting, then we came back to her. When she came back to us, we checked for her, like we counseled her regarding the weight loss and everything. So yes, initially we did not care about if she's on the obese category, or we were just maintaining her, what was her calorie requirement at that stage, what was her clinical parameters, and we were trying to not have like a muscle wasting in terms of we were trying to avoid the muscle wasting.
Okay, great. I have one more question. So, how often you do the follow-ups? Like once a day?
We can't hear you, ma'am.
Uh, Hello. Now, am I audible now?
No, not yet.
Can the team please help me from the back end?
Not yet.
Back end.
Not yet.
Am I audible now?
Yes, ma'am, you're audible.
Huh? Ha ha. Yeah. So kindly summarize, and just wanted to check how often do you call back the patients and check, and how is that patient case studies from 24. So now
Yes.
how have you just checked out how the patient is doing now?
So now, no, ma'am. Yes. So we will have a follow-up for a maximum 6 months. So
Mm-hmm.
after that, like every 2 months, we were having the follow-up. And the last follow-up I had with her was on 25th, sorry, 2025 August. That was the last follow-up, and she was doing well. She has lost some weight, not like a lot of weight as we were expecting as per as the ideal body weight, but yes, around 5 to 6 kg she has lost, and she's doing well. So 6 months maximum we try to do the follow up, and not more than that if the patient is doing well, if they don't need our intervention anymore.
Intervention.
Yeah.
Great, great. Thank you. Thank you so much. On the behalf of IDA Bangalore chapter, I would like to really thank Dr. Nikhil and Madhurima for such a great case study presentation, and also answering all our questions. So, thank you very much, and hoping and wishing you as a team all the best to taking it forward and just maintaining such a great patient care and follow up. And I hope your patient must be doing very well, because I have seen a lot of passion in Madhurima and Dr. Nikhil, and I'm very sure that you must have given a lot of aftercare in terms of counseling. So great job. Thank you very much. Thank you all the viewers.
So and thank you so much for our ICU team also for always supporting us and putting
Yeah,
us in like places where we
yeah,
can
all
learn
the
more
hard
and
work,
always. Yes.
all the hard work
Yes.
we can very well see on the screen, and the confidence that you bring as a team. Definitely. Thank you very much.
Thank you. Thank you so much. Thank you.
Thank you.
Also,